Good evening, sir. Good evening, everyone. I am Dr. Sarang, second year Drnb Cardiology resident at Drnb Hospital, Guntur. Today presenting Arriva trial. Arriva trial is aspirin plus rivaroxaban versus rivaroxaban alone for the prevention of venous stent thrombosis among patients with post-thrombotic syndrome. It is multi-center, multinational, randomized, open-label trial. So in patients with post-thrombotic syndrome, post-venous stenting, we have to check whether aspirin plus rivaroxaban or rivaroxaban alone is effective. Deep vein thrombosis is most common clinical manifestation of venous thromboembolism.
Yeah, Sarang, your screen, the slides are not changing. Just make it a full screen.
Now,
yeah, change your slide. Let's see. It's not changing. It's remaining same. Make it a full screen first. Yeah, now it's changing. Yeah. Yeah. Okay. So you can continue now. Okay.
deep vein thrombosis is most common clinical manifestation of venous thromboembolism, affecting 2 per 1,000 general population per year. Post-thrombotic syndrome is the most frequent long-term complication of proximal DVT. It occurs in up to 50% of patients who are treated with anticoagulation therapy, compression stockings, physiotherapy. This post-thrombotic syndrome is a symptom complex developing after deep vein thrombosis. Consists of pain, edema, redness, swelling, and ulceration. No treatment was proven effective to reverse post-thrombotic syndrome, leading to regression of subjective limitation and symptoms. So among this treatment, anticoagulation, physiotherapy, no treatment is proven. But recanalization of chronically occluded iliac veins with stent placement has been shown in randomized trial to restore blood flow and alleviate the functional limitation associated with post-thrombotic syndrome. Existing guidelines provide varied and inconsistent recommendations regarding antithrombotic treatment following venous stent placement, particularly concerning use of antiplatelet agents. In the Swiss venous stent registry, rivaroxaban was the most frequently used oral anticoagulant. An observational study suggested that antiplatelet treatment may improve patency rate compared to anticoagulation alone. So regarding post-stent antithrombotic therapy, presenting guidelines not provide a consistent information. In a Swiss venous registry, it is shown that rivaroxaban was frequently used. An observational study showed that antiplatelet treatment, in addition to anticoagulation, is improve the patency rate. The primary objective of Arriva trial is whether combining aspirin 100 mg OD with rivaroxaban 20 mg OD was superior to anticoagulation with rivaroxaban alone in preventing stent thrombosis within first 6 months after stent placement in patients with post-thrombotic syndrome, secondary to deep vein thrombosis. And secondary objective was to demonstrate safety of aspirin on top of therapeutic dose rivaroxaban. The first objective is patency rate and second is the safety of aspirin. The trial was conducted at 6 centers in 3 countries, Austria, Switzerland, and Germany. The eligible patients were aged between 18 and 75 years, had confirmed diagnosis of post-thrombotic syndrome, secondary to confirmed stenosis or occlusion of inferior vena cava, iliac vein, or common femoral vein, underwent successful venous stent intervention, we are on treatment or plan for treatment with rivaroxaban. So age of eligible patients are 18 between 18 and 75 and having post-thrombotic syndrome diagnosed on Villator score more than 4, and who has underwent stunting, and now they are planning for rivaroxaban anticoagulation.
You know this about Villalta score? What is Villalta score?
Yes, sir.
Yeah. So can you name them? What they assess in that score, the parameters and all?
Mhm. I have mentioned, sir, in next line.
Okay, okay. You can continue, sir. Okay, I'll see that. Okay.
The key exclusion criteria is contraindication to antithrombotic therapy, need for anticoagulants other than rivaroxaban, and acute venous thrombosis. So patients having contraindication to antithrombotic therapy and other or use of any other anticoagulant other than rivaroxaban are not included in this study. Secondary patency rate is percentage of patients with patent stent at 6 months follow-up, regardless of any re-intervention for stent occlusion. And primary sustained clinical success was defined as absence of post-thrombotic syndrome, diagnosed on Viralta score less than 4, and no re-intervention. So one is patency rate at 6 months follow-up, and second is clinically success based on Viralta score less than 4. Villalta score for affected leg consists of five patient-rated venous symptoms and 6 clinician-rated physical signs. Each rated on 4-point score from 0 to 3, none to severe. The symptoms are uh, pain, cramping, heaviness, pruritus, paresthesia, and signs are edema, induration, hyperpigmentation, venous ectasia, redness, and calf tenderness. So each component given a score 0 to 3 based on none, mild, moderate, and severe. The CIVIC 20 is a patient-reported assessment consisting of 20 items across 4 dimensions: psychological 9 items, physical 4 items, social 3 items, and pain 4 items. Each item was rated 5-point scale from 1 best possible to 5 worst. The CIVIC 20 stands for Chronic Venous Disease Quality of Life Questionnaire. Patient followed a structured schedule consisting of 3 visits and 2 phone calls over 6-month period. Duplex ultrasonography of affected leg was conducted according to standardized protocol during follow-up visit after 3 and 6 months to evaluate presence or absence of thrombosis in treated segment. So there are 2 visits at end of 3 month and 6 month, and after 1.5 month there is one phone call, and 4.5 month there is one phone call. So total 172 patients screened, 169 randomized, and 79 completed the study in intervention group, and 79 completed the study in control group. So baseline characteristic was median is around 43, women around 50% in intervention group. Active smoker were 22% intervention group and 20% in control group. So adverse events and safety outcomes. All adverse events in a intervention group 73, and in control group 47. So bleeding related treatment adverse events are 0. We will discuss it later in discussion also. The primary patency rate after 6 months in intervention group is 94.8%, and in control group is 92%. These are the graphs showing a patency rate among control group and intervention, almost the same. The quality of life, chronic venous insufficiency, quality of life questionnaire, CVIC 20. Score, pain dimension score at 3 months among interventional control almost showing 78, 79. After 6 months, 77, 78. Physical dimension score 76, 77, and physical dimension score after 6 months 72, 76. Results from March 2022 to November 2023. 169 patients were randomized to receive either aspirin plus rivaroxaban or rivaroxaban alone were included in the study. Primary patency rate at 6 months was 94.8% in the intervention group versus 92.4% in the control group. And secondary patency rate at 6 months was 100% in intervention and 96% in control group. The primary sustained clinical success after 6 months was 62%. A patient with Villalta score less than 4 in intervention group and 52% in control group. Clinical relevant non-major bleeding events occurred in 8.2% in the intervention group and 2.4% of the control group. So more in intervention group, non-major bleeding. And patency rate and clinical success almost same. Discussion. Primary patency rate at 6 months was not different between intervention group and control group. The observed absolute risk difference of 2.4% indicates that addition of aspirin did not confirm clinically meaningful benefit in preventing stent occlusion within first 6 months post-intervention. Both groups demonstrated high patency rate over 90%, suggested that rivaroxaban alone is effective in maintaining stent patency in this population. So patency rate among both groups is same. The addition of aspirin not clinically confirm any benefit. Secondary efficacy outcomes showed no significant difference between the two treatment arms, primarily due to low sample size and possibly effect size of aspirin that was not large enough. Both groups experienced substantial reduction in functional scores, Villalta score, improvement in quality of life as measured by CVIC 20 scale. So clinical improvement also similar in both groups. No major bleeding events observed in either group. Only clinically relevant non-major bleeding, notably menorrhagia, occurred more frequently in interventional groups, 8.2 versus 2.4%. The overall incidence of adverse event was comparable between these two groups. So overall adverse events are almost similar in both groups. Limitations of study: smaller sample size with only 169 patients enrolled, reducing statistical power to detect significant difference between arms. So smaller sample size. The trial was prematurely terminated due to slow recruitment, which was primarily due to COVID-19 pandemic. So trial was prematurely terminated. Studies is open label design, so may have introduced bias. It is not blind study. And 6-month follow-up period, while sufficient for short-term outcomes like stent patency, but may not have captured long-term efficacy and safety of intervention. So follow-up period is 6 months only. Long-term efficacy we have not captured. Study was conducted at experience center across Austria, Switzerland, and Germany, which may limit generalizability of results to different population and healthcare setting. So we cannot generalize these results to developing countries where hospital settings are different. The conclusion is overall primary patency rate during first 6 months following endovascular intervention for post-thrombotic syndrome was higher than expected and comparable between patients receiving aspirin combined with rivaroxaban and those receiving rivaroxaban oral. So, no any clinical benefit of adding aspirin to rivaroxaban in patient of post-stenting in post-thrombotic syndrome.
Hello.
Uh,
Yes, Arang. Hi. So they observed it for 6 months only. No? The follow-up period was for 6 months.
6 months, sir. Two
Okay.
clinical visit at 3 months and at the end of
And
6 months.
this, okay. So study showed that there was no difference in outcomes. No?
Yes, sir.
So that was it. Okay. So what are the normal recommendations? Suppose you are putting a stent to any patient, post-thrombotic syndrome, you put a stent. What are the normal recommendation? Like, what should we give? We should give antiplatelets or anticoagulation?
Uh, if in patient of different thrombosis, we have to give anticoagulation post-study.
Yeah, that is for DVT. That's okay. But for this patient, I'm saying. I mean to say that post-thrombotic syndrome patient, you have put a stent now. So for stent patient, what will you give? Will you give anticoagulation or antiplatelets?
Anticoagulation.
So anticoagulation is for any venous, no matter whether it is stent or there or not. For venous thing, you have to always give anticoagulation, and for arterial, it should be always antiplatelets. Okay.
Okay.
Yeah. And what are the normal indications? Like in which patients you will put stent? Do all patients of DVT require stents?
No, sir.
So then what are the indications? In whom all you will put stent? Okay. So basically, see, any patient with having a post-thrombotic syndrome, as in your case, that is there. So that is one of the indication. Second is patient with May-Turner syndrome. Okay. So you know what is May-Turner syndrome?
No, sir.
Okay. Turner syndrome is nothing but a vascular anomaly where the left iliac vein is compressed by the right common iliac artery. Okay, so right iliac artery compresses that left iliac vein, and because of that, there is recurrence. So it compresses that vein. No? So because of that, there will be recurrent stasis of the blood, and which will lead to recurrent chances of DVT or post-thrombotic syndrome later on as well. So to relieve that obstruction from that compression part, we put a stent there so that the stent will act as a resistance to the artery. So artery will not be able to compress that vein. Okay, so May-Turner syndrome. And another indication is suppose patient is having DVT and you are given anticoagulation and the DVT is treated. Now, suppose the patient is getting recurrent DVT despite being on anticoagulation, again and again DVT is forming, then you will be suspecting that there could be some significant thrombosis or stenosis of the artery. So if it was only thrombosis, it would have cleared, and there could be associated stenosis as well. If there is stenosis, no matter you give anticoagulation, again there will be stasis because of the stenosis. So thus there can recurrence. There are chances that again and again the clots will form there. So that's why we have to put a stent in that case also.
Yes, sir.
So what dose did we use here? Rivaroxaban, you said 20 mg.
20 mg OD.
In the other group where you gave ecosprin, there
Same dose. Rivaroxaban is the same dose.
it was same only. Okay, so 20 plus ecosprin of 100 mg they used. No?
Yes, sir. Yes.
Okay. So you know about the dosages of NOACs in DVT, in atrial fibrillation, and for prophylactics.
Yes, sir.
Okay. Or anybody else who want to answer, maybe? Shanil or Ramdas? Anybody who wants to answer? The dosages of Novax in atrial fibrillation, DVT, and prophylactic dose. Okay. So see, basically the goal of our journal should be always that the goal should not be that only we should present this journal and finish it off. Our main goal should be to see that we read about the topic entirely. Okay. So that means that you should be, after presenting this case or the journal, you should be aware of how to manage a DVT, pulmonary embolism, what are the doses of Novax and all. So main goal of making you to present journals is that you will revise their topics also along with this. So this will be an update to your known literature. So this will help you in updating as well, but you should be able to cover that so that will help you in your exams as well. Okay. So Sarang, can you tell me the dose of rivaroxaban in DVT, normal dose?
15 mg BD for 21 days, followed by 20 mg OD for at least 1 year.
Yeah. Okay. So that is usually for 3 to 6 months, depending upon whether the DVT is provoked DVT or unprovoked DVT. Okay. Similarly for apixaban, can you say about apixaban?
Apixaban 10 mg BD for 1 week, followed by 5 mg BD for 6 months.
Okay. Good. Very good. And dabigatran?
Dabigatran, no idea.
Also, okay, dabigatran, rivaroxaban, apixaban, and edoxaban. So, okay. So all these 4 drugs can be asked you in your theory exam, in practicals also. Examiners are very fond of asking you this. Okay. Also the trials related to that. So landmark trials related to rivaroxaban, apixaban. Okay, so you have to read that also for your exams. Okay. Okay. So overall, on summary, to say is there is no role of adding aspirin to rivaroxaban. Basically, antiplatelets have no role basically in the venous stenting. So that's what you're trying to say in this trial, right? Okay. Okay, fine. It was a good presentation, Sarang. Okay.
Thank you, sir.
Anybody has any other query, any questions? Okay, so we conclude our session here. Thank you everybody for joining.
Thank you, sir.